good afternoon, everybody. My name is Mike Clegg, and I'm the Dean of the Bloomberg School of Public Health, and it's my happy job to welcome you to today's lecture. As you can see, it's entitled, maybe you can't say, Tough Times, Tough Decisions, Strategies for Putting Public Health First. And in addition to welcoming our audience here, I'd like to welcome our audience on the web. As you may know, this is the third in a series of 3 grand rounds on the topic of inspiring and training future public health leaders. And the purpose of this series has been to discuss how the federal government, state government of Maryland, and the private sector are working to promote prevention and public health. And we have 3 speakers, and then we'll have a Q&A session. And our first speaker is Stephanie Corsi Bailey, MD, and she's Chief of the Office of Public Health Practice at the CDC. She served as chief of that office of public health practice since 2006. And during her early career, she was a physician in the National Service Corps, something that a lot of us started our careers in, and she provided health care in rural Dixon County, Tennessee. In 1981, Stephanie joined the Metropolitan Health Department of Nashville and Davidson County, Tennessee, as a physician, and was later appointed director of the health department. In Nashville and Davidson County, she spearheaded such programs as the Bridges to Care program, which has linked more than 26,000 uninsured residents to health care, and STD Free, which effected a dramatic reversal in the rates of syphilis in Nashville. She received her MD degree from Meharry Medical College in Nashville, Tennessee, and a Master's of Science in Health Services Administration in 1993 from the College of St. Francis in Joliet, Illinois, and her BA in Psychology in 1972 from Clark University in Worcester, Mass. She's the author and co-author of numerous publications, a longtime member of the APHA, the American Medical Association, and NACCHO, I should say. She has received numerous public health service awards, including the Nashville Urban Journal's Person of the Year Award, APHA's Romer Award, and the AMA's Dr. Nathan B. Davis Award for Outstanding Government Service. So, Dr. Bailey.
Good afternoon, everyone. When you said NACCHO, I almost lost my footing. It is NACCHO with 2 C's. And the other thing is about introductions. You know, I do appreciate the introduction, but you know, the introduction is inversely proportional to the importance of the person speaking. So after all, they do say, ladies and gentlemen, the President of the United States. So with that, let me pull up. It is my pleasure to come here and speak to you. One of my favorite subjects is public health and public health practice, and these are the times that try men's soul. So let me first remind you about governmental public health. And if one of your books has been Bernie Turnock's book called What is Public Health, which is almost a prerequisite for anyone with Public Health 101, it's called What is Public Health? He lays out the characteristics of public health. And after reading that, I always want to remind people, for me, governmental public health is the backbone of health. And whenever the topic of health is discussed, public health should be there. We do work to provide for all people. We keep humanity at the forefront. We are unique. We're the watchdog, social justice, and EPI should be as infamous as CIA. It is our science. It is what grounds us as public health practitioners. We have a special history. We have a mission, and we have a special responsibility to everyone. The prevention agenda has been changing over the years, but the basic principles of public health do not change. There was a time when we were into environmental health, which started public health, and then it was infectious diseases, and then it was the Hill-Burton Act, and we got into hospitals, and then it was chronic diseases, and then HIV/AIDS, and then we're back to infectious diseases. And so our agenda has been changing, but our principles of practice and our mission and what guides us for public health does not. We understand where and how health happens because we're all about prevention. Health is not relegated to the doctor to fix. Prevention means it's about you and I, and that 50% of that circle that has to do with lifestyle choices and habits. So we have an obligation first, and we do know that in public health, where health happens. And we're cost effective. We can do things on a dime. That's probably why we don't get funded very well, because we will find a way to protect the health and promote the health. So just a little background to know where I come from and where my passion is about public health. We have a new director at CDC, Dr. Tom Frieden, who comes from New York City. And he has set out a strategic direction for CDC that emphasizes surveillance and epidemiology, improve the ability to support state and local public health, increase the impact promoting global health, and increase prevention effectiveness of health policies, including health reform, and better address the leading causes of illnesses, disability, and death. It's not that we haven't been doing this all along, but with each director, you re-emphasize those things that are public health's domain. And then, of course, you reorganize and you reorganize and you organize, to get the best effect. But the question is put to us in this time of tough, how does CDC plan to, facilitate the effectiveness of state and locals and public health communities out there, given the tough times? In this structure, Dr. Frieden is emphasizing supporting state and local public health practice through training programs, sharing the best practices, develop and overseeing a cross-agency process of performance and accountability, increasing collaboration and communication, promoting shared leadership of public health policy and practice with public health agencies. Doesn't sound too rocket science, but let's see how it plays out over time, because I don't think there's anything on here that hasn't been a part of public health practice over the last few years. We understand that communities and assets, and sharing and networks and systems, and how one thing happens over here affects something over here. We even have begun to understand how health in all policies, and health being the preferred state of being, is where we need to be. So, what is the Office of State and Local Support? The mission for it is to achieve a healthier United States through a public health system comprising the Centers for Diseases Control and Agency for Toxic Substances and Disease Registry, state, territorial, and local health departments and tribal governments. And the vision statement to change the health of America. There are key words in here. System. Would you believe the federal government's going to understand and emphasize the fact that they are part of the system? And so CDC is going to work towards that end. Yes, the practice within CDC and without is part of the system. Another key word, shared leadership. Ooh, what is that all about? Is there a negotiation? Do we understand and recognize that states are key to input and key to answers to what happens in their own jurisdiction? Wow, revolutionary. And to change the health of America. The emphasis here, it suggests it's more than just individuals that need to change. It's to change the health of America, environmental, through policies, as well as individuals. So it takes on a different meaning. There are several functions of this new office, and this is a new thing. We're organizing now, and it should be up and running by January. Support the development and implementation of public health information technology and management. To assure rapid collection, analysis, and dissemination of data to assist in establishing program goals, objectives, and priorities. Provide guidance, strategic direction, and support for the recruitment, development, and management of the nation's public health workforce. Promote shared leadership, as I said above. Develop and oversee a cross-agency process of performance and accountability. Wow, is that new? that monitors the achievement and advance of the national public health system. You know, public health practitioners, sometimes we're scared to hold ourselves accountable. Like, I'm not accountable for infant mortality because there are more things that play in that than just what the health department does. Well, what I'd say to my colleagues, if the 600 some employees that I managed as Director of Health in Nashville, Tennessee, come to work 40 plus hours a week and did not do anything for infant mortality, then there's something wrong. The thing is that we don't put the measurement there. We don't hold ourselves accountable. It's easy to say I don't do infant mortality or I can't, but I do something. My workers have done something. Haven't been there all week, 40 plus hours. So what is it? And we have to be courageous enough to answer that question. The office looks like this. It's going to have 3 divisions: performance and accountability, public health practice, public health systems, and a little busy, but it gives you an idea of it's being formed. All the blocks aren't filled out, but it hopes to address field staff, all of standards and accreditation, and looking at how we're spending our dollars and how we're leveraging them with the states in order to get the best results and effectiveness. Those are just some of the things, but let me just skip right now to talking about the tough times. So CDC is trying to organize to be more effective in their support of state and locals, but what is really happening because of the economy with state and local public health departments. ASTO looked at their states. ASTO is the Association of State and Territorial Health Officials, and they looked at the effect of what the economy is doing to state health departments. And we had a gathering at CDC back in February to make CDC practitioners aware of the realities of external to CDC. Federal dollars make up about half of the average state's public health budget. So there's going to be an effect. 33% of states will lay off workers during this year. It was projected back in February 60% of states had reduced services, and 30% of states had eliminated programs. 22% of health departments expect a cut of at least 10% for FY09. So what does this mean? There are cuts in childhood vaccination programs, elimination of disease prevention programs, cuts in teen pregnancy prevention programs, elimination on eligibility for maternal child health services. More than half of the nation's local health departments from NACHO, which is the National Association of County and City Health Officials, have laid off employees or lost them to attrition and not been able to replace them due to budget limitations, a loss of 7,000 local public health workers nationwide. That was as of February. And local health departments report decreased funding from all sources: federal funds, state funds, local sources, levies, sales tax, property tax, decreased fee revenues. Discounting senior health clinics was a result. Public health nursing outreach, child safety seat checks, the fraying of the public health safety net providing care to the uninsured and the underinsured, decreased ability to detect outbreaks and respond to threats. We had our portfolio management states, we had senior management officials in 12 states across the nations, and their initial budget reduction was between 2 and 10% over this year. And some did across the board, some targeted programs, some programs were eliminated, and some programs were exempt based on state priorities. Disparities were expected to increase due to reduction or elimination of programs, increased expectation for local health departments to provide essential health services like health care, a limit in private and public support matching. States may rethink fundamental commitment to public health in absence of funding, and that indeed occurred in the state of Utah. Maybe we don't need a health department at the state level. That was a reality. So, the ASTO, they wrote a letter to our congressman, and in it they put this statement: public health departments are as critical a piece of the nation's infrastructure as roads and bridges. If the United States is to safeguard the health and vitality of its people, immediate investments in public health, as in all aspects of our infrastructure, are needed. So we have a lot of health consequences of economic crisis, including employment, like I said before, even elimination of TB control staff, to coastal counties to test water along public beaches, funding for 4 state staff who oversee and manage grants for injury control. Approximately 13,000 battered women and their children no longer receive state-funded domestic violence services. So I put this up here. Let me just back up a minute because I don't want you to concentrate on that right yet. I want to first just share a short story. Margaret Wheatley, in her book called Turning One to Another, in the back of the book tells a story of Aztec Indians in Mexico a long, long time ago. And there was this raging fire. It was just ravishing everything up. Everything was fleeing from it. And there was an owl that was coming was fleeing as well, and saw his brother, the bird, that was running to the nearest river, filling up its little small beak, and coming back and throwing the water on the fire. He was just going back and forth. And the owl said to the little bird, said, "What are you doing? Don't you know that you're gonna just kill yourself? You need to get out. You need to run for your life. What are you doing?" And he says, "I am doing the best I can with what I have." So my point, in this day and time, we really, our issues are raging as much as a fire, from obesity, chronic disease, you name it, raging. And we really have to ask ourselves, are we doing the best we can with the resources that we have? Our people, our money, are we doing the best we can? So the economic crisis has really caused health departments to really look and see the efficiencies and the effectiveness of what they're doing, the results. We give out money, and less than 6% of the money that we give out goes towards any results. It's about planning and process, and planning and process, and planning and process. So when you get a picture like this, we got to ask ourselves some real critical questions. Despite the good times and now the bad times, this picture shows from 1960 to 2004 infant mortality rates. And in the red, United States in 1960 was number 11, rated among all the countries from Sweden to Chile to the Russian Federation. And over the years, you see that infant mortality in the United States has gone from number 11 in 1960 to number 29 in 2004. And the circles show the disparities between blacks and whites. The blue boxes up top, it's the white deaths, infant mortality, and U.S. blacks on the, so you see the disparities. So, good time, bad time. The so what factor. We also have to ask ourselves a couple of questions. Why isn't the United States the country this country that spends the most on health? Why aren't we the healthiest nation? And then what can be done to prevent our children from having shorter life expectancies than we do? What can be done by infant mortality? What are we not doing for a GDP that's 14.9? And then why are we 47th among industrialized nations when we look at other health indicators? So for all the good times and the bad times and economic crisis, our resources are not infinite. So we have to ask the questions. The powers not delegated to the United States by the Constitution nor prohibited by it to the states are reserved to the states respectively, or to the people. Prevention It's on our mind, and we know where it has to happen in order to make a difference. We have to, this is about where our dollars go, end-of-life care, people affected with complications get the most of the dollars in traditional health care, very little going over here to safer health, keep people safer and healthier. For public health, the wedge is just a little bit smaller. We do good over here in trying to keep people health right at the top, but very little dollars are there. We've got to reach a balance. We have to balance that equation in order to be effective. When health is absent, wisdom cannot reveal itself, art cannot become manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. Herophilus, 325 BC. Public health is life's better. After all, the health of our nation are us. Thank you very much.
Thank you, Dr. Bailey. The first half of your talk, it was exciting to hear about what's going on at the CDC, but the second half was a sobering dose of reality. So thank you. Our next speaker is Dr. Aaron Wernham, who's director of the Health Impact Project at Pew Charitable Trust. And I'm hesitant to give a long introduction now because it might be seen as an insult, but I'm going to do my best. So Dr. Wernham, as I said, is at Pew. He's led health impact assessments at the state and federal levels, and has trained an array of health and environmental regulatory agencies on integrating health impact assessments into their programs. He recently moved to Pew in Washington, D.C. from Alaska, where he served as senior policy analyst with the Alaska Native Tribal Health Consortium. In this position, he led the first successful efforts in the U.S. to formally integrate health impact assessments into the federal environmental impact statement process. He also directed a collaborative state, tribal, federal working group on health impact assessments, which wrote guidance for federal and state environmental regulatory and permitting efforts. He received his MD degree from the University of California, San Francisco, and his master's degree in health and medical sciences from UC Berkeley. He's board certified in family medicine and previously served as clinical faculty in the University of California Davis Family Medicine Program. Dr. Wernham, thank you for being here.
Well, Dean Clegg and Professor Pollack, thank you very much for having me today. Let's see, I'll find the presentation. Okay, and I think that it's humbling to follow Dr. Bailey, and I think what I'm going to be talking about is one new tool to address some of the health issues that she so eloquently showed us are facing the United States. I think that really, you know, one of the issues that her talk points out is where are we going to find the time to engage in a whole new arena of policy issues that we know are driving health, but when everyone is sort of so tied to the very basic essentials of what health departments have traditionally done, how do we now build a new activity into that whole framework? So I'm talking to you today about health impact assessment. Many of you may have heard of it, but just in case, there's a formal definition there for you. I really think of it as it's much less about any specific method or even the process as it's typically defined in the literature about health impact assessment than it is about a new way and new arenas for public health to engage, usually with other sectors that are making decisions that may affect health where the decision makers have no idea that they're making a health decision. I think this really has become more and more the talk in a lot of the public health literature that other sectors make health decisions, that whether you're talking about transportation or agricultural policy or economic policy or immigration, all of these decisions that are made at a local, state, tribal, or federal level have very profound implications for public health. I think this was recognized in some ways, hundreds of years ago when we understood the connections between poverty and health, but really much more eloquently in the last few decades. Oops, going the wrong direction. Health in all policies. This is APHA's T-shirt from this year's convention, and I think this has become more and more the call in public health, but how do we get there? So I'll talk a little bit about my evolution in this field of health impact assessment, starting from my work in clinical practice in Alaska, where I worked with Alaska Natives in a number of rural regions in Alaska. And as a clinician, you become aware, particularly if you have the fortune that I did to be trained in public health and sort of know what's happening to you on a day-to-day basis from a larger perspective, that you're really out of control of a lot of what's happening in your patient's health. Yes, you know, when I started residency, we had maybe only 3 good medicines to treat type 2 diabetes, and now we have 10 or 15. However, that's really not getting at the issue of the fact that when I started in clinical practice, I had maybe 2 or 3 type 2 diabetics, and when I left, I had well over 50% of my practice being type 2 diabetics. And what's driving that? In Alaska, there are a lot of the same issues faced by rural communities all over the U.S. People have difficulty getting healthy food. They have difficulty finding safe places to exercise. They have difficulty having time because they're so economically burdened that they're having to work multiple jobs or can't find jobs. In the North Slope of Alaska, there are actually some additional factors. So the North Slope, most of you probably know, is also the sort of home base of oil and gas development in Alaska. This is the Prudhoe Bay where the Trans-Alaska Pipeline has its origins, and all the little black dots on this map are active oil wells. And what this shows you is actually that the population centers Prudhoe Bay is not one of the traditional population centers. It houses workers, but not Alaska Natives. The population centers, by and large, have been far removed from oil and gas. These are villages, Alaska Native villages, that are still largely dependent on subsistence hunting and fishing, and that's actually kept the rates of diabetes relatively low. Oil and gas development is regulated by many different regulatory structures. The National Environmental Policy Act is really sort of the umbrella. This is the act that created the environmental impact statement process, which is the way that the government looks at a decision on whether to lease lands for oil and gas or whether to allow a development to go forward, and really tries to evaluate, well, what are the potential impacts and what could we do about them? Ironically, for a 3,000-page EIS, most of them don't have any discussion of public health in them, despite what turns out to be a fairly strong legal mandate that health should be one of the effects discussed in an EIS. And this is really what led to me to get into health impact assessment. Village of Nooksut, Alaska is a small community that lies only 7 miles from a large oil development. And over the last 10 years, communities which have largely had a positive relationship with oil and gas there because it's a big part of the economy, also began to express a number of health concerns. And not only concerns related to contaminants. This is actually from the former mayor, who says that the benefits of development are clear, but the negative impacts are more subtle and more widespread and costly than most people realize. We know the human impacts of development are significant and long-term. We've been left to deal with them on our own. They show up in our health statistics, alcohol treatment programs, emergency service needs, police responses, you name it. Really what we're talking about is the fact that a major industry can really reshape a small local economy and demographics and social structure, and that this has profound implications all across the spectrum of health issues. And there's really most of what you see in an EIS is sort of impacts to animals, impacts to plants, impacts to air and water quality, but not a lot of discussion about those issues that were very important to these communities. So what we did, the local government there became what's called a cooperating agency, which allowed them to participate in the EIS, and we brought the methodology of health impact assessment sort of to the government, and after a long series of negotiations, basically agreed, convinced the Department of Interior, the Bureau of Land Management that was running this project, that health should be incorporated into the EIS, and we actually did the health impact assessment section of that. This had been a very contentious proposal, One of the general outcomes is that actually the BLM and the community came to a compromised leasing plan that was widely accepted on both sides and really protected a lot of the key hunting and fishing lands that had been so important to sustaining these communities for thousands of years. There were a number of other new mitigation measures, including sort of closing some of the loopholes for contaminant reporting, addressing some of the social ills that people talked about in a fairly minimalistic way. But we felt like it was a start. So the NEPA, the EIS process, National Environmental Policy Act, does not only regulate oil and gas development, it regulates a phenomenal spectrum of work that affects both urban environments as well as rural environments across the U.S. Again, large housing projects, natural resource development, water resource management, transportation projects, so any major highway in the U.S. If we talk about the rise of chronic disease and the importance of transportation to asthma rates, you can look at major highway proposals, for example, in the Port of LA corridor, where the asthma rates are some of the worst in the country among children, and there's currently a major EIS going on right there for a huge new highway that would carry port traffic through those neighborhoods affected by health disparities with regard to asthma. So this work within the context of the EIS process has actually kind of taken off. There are a lot more agencies now talking about health and figuring out ways to include health impact assessment in their work, and I think that's a good thing, but it really only goes so far. The rest of the talk, I'll sort of focus on what's gone on outside of the EIS process. There's really, the point here is that there are lots of decisions made that are health decisions where no one has any idea that they're making a health decision unless people with public health experience show up at the table. And I'll just give you a few examples of where this has been done. It's really quite a new field in the U.S. This is a health impact assessment for paid sick days. There's been a number of laws at the local and federal level proposed to mandate paid sick days. And really, this has actually been driven mostly historically by the labor movement wanting as a labor rights issue, not as a health issue. And actually, this health impact assessment came out right at the same time that we introduced a big media-grabbing virus called H1N1 and got a lot of attention for the notion that this is really a health issue. This is an EIS, actually, I'm sorry, this is one example of another example of an EIS, but not a federal one. This is done by the local planning department for expansion of housing development in San Francisco. And what was found is basically that the project completely complied with all existing standards for air quality regulation, but people living in buildings near the roadways shown in red there were going to be exposed to very high levels of particulate pollutions in their homes. So the outcome of this was that the planning department passed a new regulation that would require buildings, basically I think included in the building code, buildings near those roadways would have to include particulate air filtration. So again, an example where, in this case, that was the San Francisco Department of Public Health that engaged in that process. If they hadn't shown up, no one would have recognized that there was this issue. This is the Atlanta Beltline corridor, which is a huge transit project that's currently in the fairly early stages of planning to link a lot of outlying areas with fairly poor access to transportation that have all of the sort of urban public health issues that we've become more familiar with. There are problems of food deserts here. There are problems of no safe places to walk, no open spaces, no sidewalks, very high rates in some of the neighborhoods on this line of obesity and diabetes. And a health impact assessment was done, which has led to basically incorporation of health standards and the determination of where the stops will be, how the streets and roads will be constructed around it to allow sort of safe access for pedestrians. And actually, there are a number of very profound health benefits if this project is done right, recognizing that EPA recently awarded a $1 million grant to the city to help speed development of that project. There are a bunch of other examples. So in Oregon, a nonprofit health advocacy group addressed the governor's proposed legislation to reduce greenhouse gas emissions and looked at the health consequences of a number of different strategies to reduce vehicle miles traveled, so health co-benefits, and helped the legislature sort of sort through which of these policies to reduce greenhouse gas emissions would actually have the best profile in terms of health effects. In California, there's been a health impact assessment of Humboldt County's growth plan, which was commissioned by the County Department of Public Health and supported by the Planning Department. And this led to a lot of recommendations as far as growth and how growth could be managed in a way that also supports public health. In Baltimore, very close to home, there's the Planning Department recently did a health impact assessment for another light rail project, the Baltimore Red Line. So it's very new in the US. I really think that what's most exciting to us about this tool is that it really provides sort of a structured process through which public health can come to tables where we're not expected and provide input that's more than just a report with recommendations that has no relevance to all of the other sort of planning constraints that may be facing the decision maker, and actually make a series of recommendations that have a chance to be implemented. I think there are plenty of barriers. Funding is at the top of our minds after Dr. Bailey's talk. There are lots of others. I think that this really requires taking a step that a lot of people in public health aren't comfortable as far as going out on a limb. We're talking about the future. We're making predictions about something that hasn't happened yet, and really that requires making a lot of assumptions. It requires making policy recommendations based on less than complete data. But the fact is, we have to be mindful that public health decisions are going to be made by transportation departments and agriculture departments and education departments without our input, without the benefit of one single bit of public health evidence, unless we show up and at least try to help them understand what they're doing. So I am now with the Health Impact Project, which is a collaboration of Robert Wood Johnson Foundation, which has been a major funder of early efforts at health impact assessment in the US over the last 10 years, and the Pew Charitable Trusts. We have a national center now housed at Pew, and are just beginning to fund a series of demonstration projects that would address real-time decisions on proposed policies, programs, or projects at the local, state, tribal, or federal level. You're welcome to visit our website. That's where you can learn more about the project. And I thank you very much.
Thank you, Aaron. And as I mentioned in the introduction, we're going to have a question and answer session after the last speaker. And those of you who are listening on the web can email your questions as you think of them to us at MAPHTC. It stands for Maryland Association. What's it?
Mid-Atlantic Public Health Training.
Yeah, Mid-Atlantic Public Health Training Center at jhsph.edu. So that's MAPHTC at jhsph.edu. So, now our last speaker is Frances Phillips, and Frances is the Deputy Secretary of the Department of Health and Mental Hygiene, and she's perhaps the easiest person for me to introduce because she's an old friend of the school and one of our faculty. She was appointed to the post of Deputy Secretary just about a year ago, and Secretary Colmers, when he appointed her, perhaps summarized what people who know her think of her best. He said, "Fran Phillips is a passionate advocate for the health of the public and has a proven record at the local level of getting the job done. She served as the Commissioner of Health at Anne Arundel County, a county south of here, for 15 years, and at the same time was the health officer for the city of Annapolis. And during that time, she did many innovative things and received awards, which I'll tell you about. She implemented the REACH program that provides health care to the uninsured, and the Learn to Live wellness program that fights cancer and other chronic diseases. In her role as Deputy Secretary for Public Health Services, she oversees the Department of Department of Health and Mental Hygiene, AIDS, Community Health, Family Health, and Laboratory Administrations, along with the Department's Office of Preparedness and Response and the Office of the Chief Medical Examiner. And her budget, at least her budget used to be $474 million, and it probably isn't that today, but that's what it was when she started. Fran is a registered nurse, and she earned a Bachelor's of Science in Nursing from the Catholic University of America, and she holds a Master's in Healthcare Administration from the George Washington University. She lives in Anne Arundel County, and she received the Laughlin Award for Distinguished Public Officer from the Maryland Med-Chi Association in 2002. So we're very pleased to have you here as a speaker, and I especially want to thank her for her help last week. We had a visiting delegation of leaders in public health from China, and Fran was very gracious in arranging for them to visit our local health department, and they were impressed with what they saw. So thank you, Fran.
Thank you, Dean Flagg. It is a pleasure to be back here amongst friends and have the opportunity to talk. Maybe this time, unlike the most recent events, most recent occasions that brought me here, not so much about H1N1, but more about public health in general. So I'm looking forward to doing that as soon as I remove these beautiful Canada geese. So I don't want to do it in the fashion that my husband does it. That's okay. So we're going to get back to. There we go. Okay. So, yeah. Okay. Okay, now F5 isn't, there we go. All right. Okay, so my job is to give you some ideas, give you some thoughts about some of the elements that you heard from both of the previous speakers, and as they pertain specifically to here in Maryland, to public health at the state level, and I can't help but also talk about public health at the local level, because that's where the rubber really meets the road, right, Dr. Bailey? Dr. Bailey and I had the wonderful chance to know each other back in the day when we were at NACCHO, not Nacho, at NACCHO, as local health people, and we have enormous respect for the work that goes on in local health departments across the country. So it has been tough times, and certainly you've heard a little bit about that. Unfortunately, I'm going to give you some more sobering information, sobering news from Maryland. But I want to take an opportunity and paraphrase our Governor O'Malley, with regard to this business of economic cycles, and his viewpoint, and certainly it's one that he is not hesitant to share, is that tough times leave, tough people do not leave. So there are very, very many tough people in public health, in the federal level, at the state level, and the local level, and we're here to stay, right? We're not going anywhere. We're here to stay. This economic downturn is cyclical, and unfortunately in public health, our work is counter-cyclical, because as the worse economic times get, the more the challenges and the demands are for public health, but we're not going anywhere. So what I'd like to do is really briefly recap some of what you've heard and apply it, as I said, to the state of Maryland and to our wonderful 24 jurisdictions. What are we facing here in terms of what we look at as we look at the public health needs across the state? And this is no different, I would suggest, than the rest of the country. Chronic disease, the burden of chronic disease is enormous, and it has begun actually to become recognized inside the Beltway, inside the Washington Beltway, with regard to the discussion going on healthcare reform. So that there are elements of recognition. Certainly last year with the administration's stimulus package, the ARRA funding, there was a very, very important line item in that bill that passed that set aside $650 million for chronic disease prevention work through the CDC that will go on in local communities across the country. The burden of chronic disease is one that we're all paying for, and until we get ahead of that curve and start looking at the behaviors and looking at the environmental and the social conditions that lead to those behaviors, we're not going to be able to catch up. So certainly chronic disease is the burden that we all share. I'm not going to talk about H1N1 that much, but we all know not only the traditional communicable diseases, but the emerging infections are ones that are taking a serious toll, and particularly a serious toll on a very small group of public health workers, and those are our epidemiologists, like gold epidemiologists. So tremendous demands and certainly a lot of opportunities. Bioterrorism and prevention and preparedness, since 9/11, it has been a new world in public health. It is no longer a 9-to-5 desk job. If it ever was, and certainly for the EPIs and the infectious disease folks, it never was. But public health departments still only have one shift, unlike police and fire departments. You know, they've got 3 shifts. We've got 1 shift, and 1 shift of people have the responsibilities for maintaining the safety, the health safety of the entire population 24/7. So that is a new responsibility, and I have to say it's pretty much underfunded. So we'll get back to the funding in a minute. The rapid communication, it's not enough anymore to update your website periodically. You got to do it every day, otherwise it loses credibility. What we've learned in this most recent pandemic is not enough to work with the media. It's not enough to work with on the website, or for partnerships like this one to work on webcasts in order to communicate, to get information out. We need to learn how to twit and use all kinds of social marketing, whether that's Twitter, whether that's Facebook. We need to get words out in languages that are not our own, or not our native languages, and in modalities that are, at least not for some of us, are all that comfortable. So the demand for rapid communication, as well as the public's demand for not only transparency, but a healthy dose of suspicion, skepticism, I guess would be a better word. I'm from the government and I'm here to help you. Well, that doesn't get you anywhere. And so in order to have the credibility, public health certainly has achieved. The consequence of that is that we need to continue to walk the talk and to recognize the raised expectations and to deliver on them. Less resources available, we'll talk about that later. Low visibility of public health, well, yes and no. Usually we were kind of the back office people as opposed to the kinds of specialties that capture the hearts and souls of broadcast, you know, of continuing TV series and whatnot. That's changing a little bit with regard to this pandemic, and I want to say that this is an opportunity for public health to demonstrate what it is that we can do and how important it is, and as a way of promoting public health to our potential workforce, not only to the public at large, but most importantly, and I'm talking to all the young people here, people who have an interest in public health, you're investing your hearts and minds and souls in public health education, and to go out there and to be an ambassador for your colleagues and for other folks to bring them into this wonderful mission-driven and mission creep, but mission-driven profession. There is a danger of mission creep, and part of that is because the people that get into public health are passionate about what they do. They see connections in our society. They see the opportunity to make things better, and what happens is a lot of times we have difficulty saying no. Can't do it. And so that's where this mission creep comes in. We have the tendency to say, okay, well, we'll take on another batch of restaurants to inspect. Or, okay, we can continue to maintain the same kinds of quality family planning clinics, even though we've had our budget slashed 30%. We'll try to make it work. At some point, it has become clear to most health departments that we can't continue to nick and nick and nick and nick. We need to make tough decisions, and we need to roll back what we were doing because it wasn't nice to do, like to do, to the very, very most essential, what do we have to do? And that really calls into question tough decisions that need to be based on metrics and on accountability. And yes, stepping up and saying, this is my job and this is what I'll be held responsible for. In Maryland, we don't have an option about that, and I'll talk about our governor a little bit more about how important accountability is. Workforce recruitment and development. I don't know, unless Ginny Seiler, who's one of my wonderful colleagues here, has the number. I don't know the percent of state employees in public health who are eligible for retirement right now. Ginny, do we know? Do we know that? All right. Okay, that was one of those text messages on the way over, so don't hold Ginny accountable for that. Let me just say it's a lot of people. So when you look around in local health departments, you see a lot of people of my generation. And that's both a bad thing and that's a good thing. It's a bad thing in terms of succession planning, in terms of retaining the institutional knowledge of what we did, what worked, what didn't work, how programs work together, the who's who. But it's a great thing for new people who have an interest in coming into public health from a lot of different avenues and to say, you know, I can apply my skills as varied as they are to this great organization that's about to lose X% of their staff. So the turnover in public health certainly can be a threat, but it also can be a marvelous opportunity for us to leverage. Okay, tough times in Maryland. Yeah, we have them, and has been alluded to before. There's a lot of different state rankings of health indicators, health status. This is one, as you probably know. This is America's Health, United Health. This is the most recent ranking for Maryland. And we've got some things that we need to be really proud of here in Maryland. The low prevalence of smoking, I think we are the second state in terms of the percent of adults, or actually not even adults, the overall percent who are smokers, as well as our immunization coverage for kids is really good, and we have had a quite significant decrease in our cancer death rates. I would like you to put an asterisk next to the smoking and the cancer business, because we're going to come back to that in a minute, because there's clouds on the horizon there for those strengths. Those kinds of things didn't happen overnight. You know, people, when you look at changing the meter, making the dial come down a little bit in terms of these kinds of indicators, it takes a sustained, comprehensive effort, and that's certainly what we've seen for a decade now with regard to tobacco, and it has really paid off here in Maryland. Likewise for cancer early detection and prevention. Those take a long time to make improvements. We've seen improvements. There is, as I said, some serious threats on the horizon. Here in Maryland, those of you that know, we are facing a disproportionate increase in terms of our infectious disease. That's tuberculosis, that's sexually transmitted infections, and certainly that's HIV/AIDS. And we continue to be a state that has rates for all three of those far above the national average. Our violent crime rate also above the national average. And our rate of uninsured has increased. Overall, our rate has been pretty good, but look at that 55% increase, and that's certainly reflective of the overall economy, which Maryland, even Maryland as a relatively affluent state, is not immune to. Health disparities, any public health problem that you look at, wherever you look, you're going to find them, and if you don't look, you're not doing your job. And I say that as a public health, a local public health leader that had a really healthy, upbeat, waterfront type of population, a jurisdiction of about 500,000 people. But if you drill down and if you look at zip codes in Anne Arundel County, as is the case around the state and I would say around the country, if you look at the pockets of where people actually are living, that tells a very different story, and that's actually true here in Maryland. We have a county in Maryland on the lower eastern shore that has infant mortality rates that equal the third world. It is outrageous that we continue to have preventable deaths. 632 babies die before their first birthday in Maryland every year. That is a statistic that is shocking, and it's one that Governor O'Malley has said, we're not going to continue that. Doesn't matter what the economic forecast is, we are going to change that because we are a state with the wherewithal and with, if not the public resources, the private resources to make a difference. So it's not just talk in Maryland. Governor O'Malley has convened his leaders, and certainly leading with Secretary Colmers, and has said, we're going to change this, and we're going to put some numbers on the strategic goal of reducing infant mortality in Maryland. And the number is 10%, and we're going to move that 10% by the year 2012. So what that means in very real terms is that we have to find 62 preventable deaths, babies who are born who we can prevent their death before their first birthday. We've got to find those babies, we've got to apply evidence-based interventions, and we've got to celebrate those babies living to their first birthday. Do you see what a challenge that is? This is not about talk. This is about outcomes and about results. So it's an environment that if you measure it, then you can make it happen. And if you don't, then there's not accountability, and there's a great likelihood for not enough change. All right, let's talk a little bit about money here. And this slide, I don't want to talk about, just look at the pieces of the pie here. This is DHMH's budget. DHMH stands for Department of Health and Mental Hygiene in Maryland. It is a super agency as opposed to, in some states, public health is a separate agency. In Maryland, it's consolidated with Medicaid and with the state facilities for mental health and for substance abuse. So if you put all that together and you look at the public health funding, you can see that little blue sliver is the amount of state money that goes into public health, pure public health as we're talking about it, as opposed to MHA stands for Mental Hygiene Administration, the DDA stands for Developmental Disabilities Administration, ADAA, Alcohol and Drug Abuse Administration, then there's this administrative, and then you see that major slice, which is Medicaid and the Children's Health Medicaid CHIP program. The fact is that we continue to have people who absolutely need tertiary prevention, people who need access to medical care. These are Marylanders who need it, they get it, but they get it in terms of relative proportion. Look at the slice of the blue, which is public health, which works towards prevention, and look at where we are with regard to the rest of the budget. It's not unlike what the national profile is, and it's a darn tough thing to dig our way out and to make the case that we need $1 in public health when it's a zero-sum game, and that dollar would come out of any of these other slices of the pie. That's tough. In terms of just looking at 1 year, what we're in now is FY10, fiscal year 10. Last year was called fiscal year 9. So take a look at DHMH, big enterprise. It's over $8 billion. Okay, so in general, it lost hundreds of millions of dollars between, 133 million between last year and this year. Look at where some of those losses came from. CRF stands for Cigarette Restitution Fund. Cigarette Restitution Fund is like every other state. This is as a result of the Master Settlement Agreement, whereby the tobacco companies pay the states in retribution for the cost to the states of tobacco. Look at the tremendous cuts that have been sustained in Maryland in the past year for one piece of that Cigarette Restitution Fund, which goes to cancer screening and prevention. So these are the mammography screening programs, these are colon screening programs that go on at the state level, as well as, for example, the quit lines, as well as at the local level, to bring uninsured people in and to have cancer screening. Look at the tremendous reduction there. Secondarily, tobacco. This is what worries me so much about the other side that said we're doing great with tobacco, we're doing great with cancer death rates. Look at what got cut out of the tobacco. This is tobacco prevention. This is tobacco cessation programs. These are programs that are working in schools, in communities. This is not something that any of the legislators or the governor wanted to do. This was a reality, and this is a reality that statutorily needs to come back next year, and these funds need to be restored. So we'll talk about that in a minute. And then lastly, the cut to public health. I'll show you that in the this is the cut from last year, is the blue bar, and now we're down to, in terms of the state money, to where the red is, a tremendous loss in terms of both state and local public health. And so what this shows is the net loss. The net loss is a loss of about 30%. And let's take a minute and look at this. What is that increase in federal funding? So what happened? What did we get new federal money for? These are percentages. These are not quantitative numbers. We got new federal money in 2 areas, and there are 2 areas that are welcome, and we certainly are going to spend every dime, but it doesn't go to the public health infrastructure. One area where we got $10 million of new federal money in Maryland was in the WIC program, Women, Infants, and Children Nutritional Supplement Program. This is a really important program for low-income working families, and these dollars go straight from the federal government, Department of Agriculture, through us, straight to grocery stores, basically, for vouchers for supplemental foods. This is not public health. This is a food supplement, and definitely it's necessary, but don't for a minute think that increase in federal funding has to do with increase in the public health workforce or our infrastructure. The other area where we had an increase in federal funding was in the addressing the pandemic. So we have had an increase of about $20 million from, or funding from the CDC for about $20 million to address this worldwide pandemic. So between WIC and the pandemic, that doesn't leave us dollars to address what these other very, very serious cuts have been with regard to the traditional public health infrastructure. Oh, and I want to go back for a minute because there's another point here. We at the state level took a big hit. 16%, but look what happened. Look at that middle bar, 45% cut. There was a 45% cut in the funding that the state transfers to local governments, to local health departments around the state. That's unbelievable, 45% cut from one year to the next. How did that happen? Well, I'll tell you how that happened. That funding is thought of by the legislators, by the political leaders in this state as aid to local governments. So that block of money is all commingled with what the state sends to counties to run libraries and what the state sends to counties to run community college, and there was insufficient information and advocacy by public health at all levels to educate the people who made this decision that this is not just a block grant to counties. When you take a 45% cut, 46% cut to local health departments, you will cut the school nurses, you will cut environmental investigations and safeguards, you will cut family planning and maternity programs, you will cut case management for at-risk infants. So just now, the reality of what this means in every county across the state is becoming in the awareness not only of the elected folks, but of the citizens themselves. And so that's the beginning of change, when people understand how valuable public health is to their family, to their schools, and their community. That's when we can get some traction and we can get some protection. So this is the last slide because I want to save time to hear your ideas, your questions, and certainly what are we going to do about these tough times and tough decisions. You got to make a business case, and certainly to the extent that we can quantify what we do, we can measure it, and we can make a hard case as to why wellness clinics for employers make sense. Why is it a good idea, for example, for the state of Maryland to include in their health benefit package immunization coverage for immunization for state workers? You got to make the case why the dollar spent on that is worth it from an employer standpoint. We have successes, and we have great people around the state and around this country who are doing wonderful things. Health impact statements. Yeah, when there's an ability to measure what it is to our children when we build a high school so that nobody can walk to it, everybody has to drive to it, and nobody in the community can use that high school for after hours, for summertime, for any kind of recreational. When we have the ability to quantify that, then people will make some different decisions. The partnerships, the creative partnerships that exist in public health are just now coming on board, where people are seeing, we can really work with, for example, the corporate sector, the business sector. There are areas where our agenda and our mission are aligned and can be dovetailed with some unsuspecting partnerships. The media has to be fed every day. Every day there's a television broadcast. Every day there's a newspaper. And so the editors and the reporters every day are looking for stories. And to the extent that we can tell our story about what we do in human terms, not in numbers, not in generalities, but looking at families or schools and look at how we make a difference, it's great material for the media. And I'll end on that to tell our story, because we got a great story to tell. It's one that is under pressure right now, but I think I will agree, or you will all agree, that the public health folks are tough, and we're not leaving until we tell it. So I'll stop here and be glad to get your comments later.
Thank you, Fran. I'd like to ask Professor Tom Burke, who's Professor of Health Policy and Management and who's the Associate Dean for Public Health Practice, come to the podium and run the Q&A.
Thank you, Dean Clack. That was great. And I think we have to turn up the lights a little bit over there, maybe? No? Okay. Great. Well, you've seen that energy. You've seen the opportunity before us. You've gotten some depressing news, so some of you may want to think about PhD programs after your master's degree is here. On the other hand, what an opportunity to rethink, to advocate, to answer all those challenges we heard so well, and to think about the new methodologies like health impact assessment to really make sure public health is at the table. So I'd like to invite your questions now, and also those from the web. So Molly, if you have any questions for the panel. I have one to begin, and that is, so how do we at the school prepare our students for what you're facing? So I have this dream of my students taking over leadership roles at all of the agencies and institutions that you represent, and how do we train them better? How do we make sure that they are equipped for the modern challenges of public health into the future? If 5 of them could show up tomorrow, what kinds of tools would you want them to have? And I'll ask the panel.
Well, I'll start, and I'm sure others have some comments, but there's already a change going on here at Hopkins, and I think that's typical, or maybe typical around the country. I hope it is, and that is an attention to practice, and certainly with Dean Clagg's leadership and you, Tom, as far as bringing practice into the classroom so that when students come to school and begin to take classes in public health, to have some idea, for those that haven't worked in public health before, to have some idea about what it's all about, and to have the opportunity to spend time in health departments, working either in a formal way with a preceptor or on a rotation, or in an informal way, so that there are projects that we can spin out, that we can propose, for example, short-term projects that will have a real benefit for those of us in public health practice, because we have very, very limited supply of people that are in the specialties that you are training. So for example, in H1N1, there are probably between 8 and 10 projects right now, small projects that we would love to have students engage on, to look at what is the effectiveness of some of the outreach, what is some of the surveillance, the biosurveillance indicators that we've looked at as far as emergency room and hospitalizations and deaths, and how do these all align. Tremendous amount of contemplative, but not scholarly academic thinking, but contemplative thinking that those of us that are in the trenches every day often don't have the luxury of doing.
Great, thank you. Stephanie?
First of all, I want to thank this panel. This is the first panel that I've been on that each of the presenters stayed within their timeline, so we have enough time for questioning. I've been on the end when the first person has talked forever and you're rushing at the end, so I really appreciate, I think we give ourselves a hand. I do. I was watching the time. I thought this is great. But I want to say, you know, you're training students to become leaders, and it always is amazing to me when people talk about public health. The first thing I ask them, do you know your local public health department leader? You know, whether it's a hospital CEO or whatever. And how many of you are involved in your own community? You know, we live in communities, and each community is about doing their community processes with their local health department and their local assets to do that. So how many are really involved? And so the key, the tool I would have them come to me with as a health director is the skill of listening. You know, it's about listening and collaboration. It's not coming to tell what is to happen because I've been in school and I know the answers. You know, I am the scholar. It's a type of benevolence that an appreciation for whether it's a tribal community or a rural community that you have to appreciate your own community. So how are you involved? What are the assets? What are the roles? So I think that gives you the keenest insight into your next step to be a part of thing. I have to also mention that it's been about 30 years since the public health advisory classes, particularly around CDC, has been instituted. And about a year ago, we started an apprentice program in 12 states, and we now advanced it to about 10 states where we're taking bachelor level prepared students and putting them with local and state health departments, you know, to fulfill their need and, like you suggest, do projects and learn on the ground so that you could be marketable to local and states. Because traditionally, a lot of people that come out of formal practice or formal education very seldom go into health departments. You know, they go in administrative positions, they go other places. And I'm not saying that you have to go, but your knowledge that you learn in schools of public health have to be applied wherever you go, because it is health in all policies. It is health in all industries. It is health in all places that you may go as an administrator. But the key for me is being oriented to communities and being oriented to listening and collaboration and recognizing that it is a system and it is about those pieces.
Question in the back.
They are on the website at CDC.
A practical question of how do we find out about apprenticeships, and we'd be glad to help as well.
Yes, and Tom knows.
Yeah. Yes?
I have a question. It's partly about health impact assessments. The last presenter showed the slide showing the distribution of the state expenditure for health, and it was a majority on Medicare or Medicaid and CHIP programs. How can we use our health impact assessments to show that if we are running the Red Line through Baltimore, the light rail project, we can save this much money in our chip costs that we're gonna have. How best can we do that with health impact assessments?
Right, so thank you for the question. I think that really one of the very important tasks that we face in public health that each of us has pointed out in some way or other is linking. We're not just asking for handouts. We're not asking for money. We're asking for money to do a job, which in many cases is actually going to save society a lot of money in the long term. So we need to develop better tools, and I think continually work on developing better tools to assess the links between a policy decision, whether it's the Red Line or the Farm Bill, and public health. And so we really need, I think, ultimately the vision of health in all policies has to include a vision of developing a system wherein we actually track and are accountable for the health effects of all policies. And that takes then, I think, really, and this in some ways goes back to your first question, Tom, what to do to prepare public health leaders for the future. When we say health in all policies, I think it takes to some extent an evolution of public health practice out of the public health department and toward civic engagement, where health officials and public health practitioners in any setting and medical practitioners as well know what's going on in the local legislature. We know when there's a bill coming up that may have an impact on public health. We're new to Montgomery County. We just found out that there's a bill that there's a law. It was a bill and it was enacted that apparently prevents school gardens because there's some concern that the legislature had about attracting pests. So I think had we shown up at the table and educated the legislators about childhood obesity and the concerns about lacking access to fresh fruits and vegetables, maybe that decision would have been made differently. So I think engagement and then trying to build accountability and tracking into each law that we think is important to public health.
Yeah, it's not so much starting with the end in mind so much as getting out there and doing the health impact assessment and seeing where they go. And it leads to the accountability factor. I also want to mention that in this day of technology, there are a lot of simulations and things that particularly Bobby Milstein's work, if you pull up some of his work, he just sort of created what we call the health protection game, where you can put factors into the simulation, and look 50 years out, like to 2050 or so. And with technology, you can do these type of things now. And so a policymaker says, I want to lower the insurance reimbursement to doctors. Will that decrease costs in healthcare over 25 to 50 years? Or will it decrease disparities, And you can sort of play that out and give some semblance of what decisions being made today may cost or may impact down the road. We have short-term thinking, and we make decisions, and the consequences, unintended or intended, are just enormous down the road. So with technology is allowing us to be creative and sort of simulate some policy decisions so that even we can bring policymakers into the game, about life decisions, and they're not that go beyond just a term.
Couple of points really struck home that have been mentioned, that, for example, health impact assessments typically is an effort that's done in a political arena, whether that's at the state level, federal level, or more typically it's a local level. So these are zoning decisions often. And so it's really important that people know who their local elected people are, who is on your town council. And fundamentally, what is the process? How locally does an ordinance get passed? How does a bill become law in a state? It's high school civics, because it's civics engagement. So I ask people in the public health, in the health department, do you know what the difference is between a law law and a regulation? Do you know how you could actually prohibit zoning for convenience foods close to a school? Or you could zone in more to incentivize grocery stores that have fruits and vegetables? Do you know how that could work in the mechanics of zoning in your county? It sounds so removed from childhood obesity, but it is actually the tools that we need to get much more familiar with. It's not enough anymore to say to mom, you know, your child is over the percentile and you really need to do some more fruits and vegetables at home. That's over. We continue to talk again and again about individual behaviors, but we forget what's going on in the school cafeteria, what's going on afterwards during the after daycare, and we forget what's going on that's in the vicinity of the house. So these kinds of the fundamentals of, do you remember your high school physics about how a bill becomes a law, becomes really important when we're dealing with these kind of strategies.
I'm sorry, you started something. Maybe you shouldn't have us together.
There's a
Because
new
this
course
right-
developing here. I'm taking
I mean,
notes.
we're just feeding off each other because we're the same path. And if we do this right in our communities, people in communities become our state legislators and our federal Congress. You know, so you begin to build from the local. That's where it happens. There's no national street. There's no state street. It's in local communities, and if you get it right there with the engagement, true public engagement, true civic engagement, and true policy making, and true watchfulness and surveillance and epidemiology and accountability, then we'll, you know, it's a win-win situation. Okay, we're good. We're ready.
In the back.
It sounds like one of the things that you're really trying to do is build the credibility of public health, which is what's needed to get people engaged in that way. But I think in order to do that, you have to figure out how to talk about public health in a really simple but convincing way. And I get the sense that too many public health leaders aren't good at doing that, whether they're speaking to the general population or whether they're speaking to other politicians who aren't in public health. So could you talk a little bit about what's being done in your organizations to help public health professionals communicate what they're doing and how?
You're right. Communication and the words that we choose are so important as to what kinds of pictures we can conjure in the listener's mind. So if we talk about the rate of childhood obesity, we're going to get a lot of legislators that are going to be zoning out. But if we talk about, have you looked at fifth graders lately and what size clothes they wear? You know, if you make it very, very real and something that they can relate to, and then build sequentially from there, we probably shouldn't say public health as much as we say public health, because people really don't know what we're talking about. If we talk about wellness, if we talk about health, but when you start saying public health, and then they're thinking the public option, and maybe I don't like that, you know, so we just really have to be careful about the words we choose.
Fran, don't bring up the
Ditto,
public
I mean-
option.
Yeah,
I'm a rabbit.
okay. There was just an article about the challenge of communicating public health to the public in AJPH, which sort of highlighted the challenge of talking about the social determinants of health, which is something that means a lot to most of the people in the room, but really does not mean a lot outside the room, and even just sort of which audiences are going to hear what. You know, I think to a large proportion of the American public, health is genetics and public and personal responsibility. It's sort of personal choice, and sort of other environmental factors and living conditions and economics affecting health. It's a long shot to get that message across unless we do exactly what you're suggesting, which is really emphasize it. So Tom, he's talking about the course for leaders, which is communications. I think you're right.
Marketing,
Needs
right.
to be a part of.
One of a great mentor of mine said to me, Stephanie, communication is the science of the future, and it indeed is. And I'm struck with your first part of your comment about the trust factor relating to public health. And there have been several polls out, and a lot of people, if you separate public health from government, you know, they trust public health. You know, they as a local leader, they sort of trusted me to combat TB and not let, you know, infectious diseases get in place. But the challenge is still there, and it is in the communication and how you relate that sensitivity, that understanding about community dynamics and assets, and about you know, talking to your neighbor, you know, you being the one, the face, you know, to your neighbor. I remember the story of when after 9/11 and all the anthraxes were, I mean, we were doing anthrax almost every half a day. We had to change our policy because everything was anthrax, everything, you know, powder and, you know, whatever, coming out of potato chip bags or whatever, everything was anthrax. And I remember a young student coming from one of our local universities in Nashville, coming to the health department with a bag, she thought it was. And of course, we were always calling on our full alert alarm. And the police come there, and they did not want to come into the health department building because this person had brought the bag. And so you have to know how to get to people, as Fran was saying, what's the message, how to communicate. So I said to the officer, okay, who is it that you could listen to that no matter what they would say, you know, you would believe? He said, well, my grandfather, my uncle or something. I said, give me that number. So I had him call that person, and I told him who I was and talked to him. So you have to know, everyone has to be that mouthpiece and be that, but you have to come with some common understanding of what it is we're talking about. And I think that's where public health comes in, because everyone gives a nuance about what public health is, and it's about the health of the public. That's as simple as it is. It's the health of the public. So communication is key, trust factors, all of those, and who should be the better messenger, you know, to help change the health of America.
We got a great question from one of our folks out on the web, and it follows up nicely on that one, and it's about advocacy. I think, Fran, you talked about insufficient advocacy for public health. And so the question is this: could each of you talk a little bit about the idea of the zero-sum game in terms of funding and the implications for practice? In tough times, should public health advocates argue for more money related to other things such as transportation and education? Or how do we do that when it's a balancing act?
Well, I think one of the things actually is to look at kind of laterally, look at the kinds of resources that are available that may not be nailed down. They may be discretionary to some extent, and to see where there can be public health gains in there. And you mentioned transportation is clearly one of them, that there are opportunities in these major transportation projects to build in health impact assessments. There's opportunities to do surveillance that heretofore hadn't been happening. But we need to look not frontally but laterally to see those opportunities and to recognize them when they come across. And a lot of times they're not the big headline things. They can be relatively small. They can be for heaven's sakes, they can come from, you know, the drug companies or the insurance companies. So long as they are the ability to work in concert to get the job done, to get the needs met, it is important that we look really, really broadly, because what's coming, as you saw through the pipeline for public health, right now, that pipeline is pretty constricted.
I'll just say one thing: there will never be enough money. There will never be enough money. You ask people, the first thing that says, I need more money. And I think we can show that we aren't as serious about the so what and the result. So I think there is a lot of looking at resources, where they are being used now, and for what, and so what, because there will never be enough money to do everything you need, so there has to be prioritizing, and you do that. Tom's initial question when he asked was, where will we find enough time to introduce new tools or to do new things that make us more effective? Well, it's a matter of reorganizing for success and organizing to get to results, as opposed to just doing something because we feel good.
I missed a question back. Yes. In the white.
Recent budget cuts, and with fear of future budget cuts, how do you decide where to allocate your resources, or does that change your priorities and how you foresee projects?
And that's the toughest question. That really is, because there's never enough money, there's always growing needs. And so that's really the leaders, that is the challenge. How to make those decisions and how to do that in a collaborative way so that there is momentum and there's spirit around the decision once it's made. And so it's certainly not a decision that can be made by the bean counters, can I say it, the accountants. It's not one that can be left to the elected people, because the elected officials need to be informed, and so we need to be the voice of truth to power in that. We need to advise what is the consequence if this item goes or if this one doesn't. How do we come up with those kinds of prioritizations? Yeah, you got to come back to the numbers. You need to have the ability to have surveillance, and that's one of the easiest things to cut. Surveillance, let's get rid of all those surveys. And yet, it's the fundamental backbone of what we making scientific evidence-based decisions in terms of budgeting. What do we rely on? That's what we've got to rely on. So the ability to maintain the surveillance, to maintain the metrics is really important. And if you can't say it in public health terms of surveillance, then you might have to say it in terms of a market survey, because we need to market your constituents, Your Honor. So there are some ways to do that, to make those decisions, but it's really important, as has been pointed out, that it is a spirited decision, that there's some consensus behind it. Otherwise, it's a decision that's going to blow up on us. And we've all been in that situation where we've made some budget cuts and then come to find out that we didn't have all the information, we didn't know all of the facts as far as what the consequences, and we also didn't know who the advocates were. And so that's a wake-up call that many of us that have been in those shoes don't want to repeat.
So I just want to, that was a great question, and I don't know if our listeners heard the question. How do you decide? And Fran, if that's the role of a school of public health, to improve the evidence base for informed public health decisions, and that's our challenge, because that is the toughest question, toughest politically and sometimes toughest scientifically. There was one more question, and then we're going to run out of time here, but you have a chance up close and personal at our reception. So I did see one more hand up. Yes.
So my question actually about evidence-based practice. Three of you both mentioned about accountability. So working in academic setting, I'm thinking about the evidence-based practice, specifically evidence-based public health practice. And Dr. Bailey has mentioned the word called system. So I want to put my question in a system perspective. How evidence-based practice from the federal level and the state level, also in the practitioner level, how they are linked together or disconnected, or what is the coordination between different levels?
So the question was a tough one again. A good follow-up question on evidence-based practice, and how do we coordinate at the different levels of public health practice, federal, state, and local? And I'm glad I'm over here and you guys are over there.
I was going to say you answered your own question. It is disconnected, and that's the whole emphasis, to try to keep in mind we are a system. Even the what is a new sort of research area, public health systems research, is fairly new and yet incomprehensible to some scientists, in public health. What does that mean? What is that about? You have things going into this black box between workforce and money and organization and things, but how do they shape up to get the best result or the best effect? That's public health systems research in here. How do all those things, and what portion of workforce versus this kind of organization versus this kind of service delivery goes together in order to be the most effective? That's a relatively new area of research that is getting more legs out there. But we are striving with Fran in place in Maryland and more practitioners in place at the federal level, and we got our external lookers out here pushing us. We're going to make the system get better. It's very disconnected presently.
Well, one of the ways that the system gets better is that the people with the money can say, here are the rules for spending the money. And usually those of us either at the local level or the state level, if it's the federal government talking to us, we kind of bristle and say, oh, what is it now? But evidence-based practice begins with the idea that we're not buying T-shirts anymore. We're not putting money out for nonsense. We're not doing widgets. We are going to have an alignment of what we know works around the country. That takes a lot of political muscle to do that, and what specifically I'm thinking of now is the funding that I mentioned earlier, the $600 million for chronic disease prevention that's in CDC's budget. And boy, you know the states, we all were just waiting to get our hands on this money, and everybody else got their stimulus money, and we kept saying, when are we going to get the grant guidance that came out was evidence-based all over it. And so there's not going to be any, as I said, T-shirts or any kind of gimmicks. It is very rigorous. It is defined as far as these are the interventions that we know work in communities for childhood obesity. These are the ones that we know work for tobacco prevention. And if you want to get funded, you're going to do that, and you're not going to do the other nonsense. And so that takes a lot of gumption to put those kinds of frameworks out there, because you've got 100 senators, and they all want something to bring back home. It's not going to be that kind of a free-for-all. So that's one example of evidence-based practice and how you get alignment. Well, he who has the bucks gets the alignment. And in this case, it is absolutely necessary to do. Otherwise, we won't have the models to look back on and to say that this works. The other comment I want to make about evidence-based practice is this unfortunate business that blew up a week or 2 weeks ago with regard to a group that I hold dear, and I know you do, those of you that have had to weather some of the controversies politically with regard to what to pay and what to spend money on. And I'm talking about the United States Preventive Services Task Force. And you all saw what happened when a very well-intentioned, very informed, and very good set of recommendations hits the national media at a bad time and with some kind of wording that could have been done better. You know, there could have been some better communications on that one. The idea of evidence-based practice has got to be essential to what we're doing in public health. If not, then we're doing intuition-based practice, and none of us want to do that. But again, it shows how important it is when you've got the evidence, when you've got the knowledge, how important it is to look around, to listen, and then to communicate it in a way that's going to be effective. Otherwise, it can be pretty disastrous. Not to end on that note.
That's well, we're not going to end on that note without saying this is the third in our series of leadership grand rounds that was sponsored by Pfizer. And I just want to give some thanks to people who made it really possible. And starting with Dean Mike Clegg, who really urged us to go forward with the application and do this. And I want to thank you, Mike, for your support. I also want to thank the people who made it really happen. And they're the foundation of the practice committee in the Department of Health Policy and Management, starting with Beth Resnick, Dr. Shannon Frateroli, Dr. Keisha Pollack, and Jim Cusick. So thank you very much. And panel, what a great job. And I'm looking forward to I'm looking forward to more questions over perhaps some refreshments at the reception. And thank you so much.
Thank you.